Hello everyone. Today we're facing one of the most serious challenges in medicine of our time. And this relates to the sudden appearance and proliferation of the coronavirus disease. I would like to explore with you today about coronavirus and thrombosis. What do we know so far? Here is a study that was reported recently talking about abnormal coagulation parameters and how they're associated with a poor prognosis in patients with novel coronavirus pneumonia. In this particular study, 183 patients from Wuhan, China, were studied with their coagulation tests, and the mortality was 11.5% in this population. And in those patients that had coagulation test abnormalities, elevated D-dimer, elevated fibrin degradation products, prolonged prothrombin times, and prolonged thromboplastin times, those were all indicators of mortality. And the levels in patients that died were much different than the patients who survived. In addition, disseminated intravascular coagulation was seen in 15 of the patients, which was 71% of those that had died, compared to only one of the survivors. And you know, this is a very serious disorder, and sepsis triggers this, and that sepsis can result from a viral infection and lead to activating clotting, so there's an increased thrombin level in the circulation, as well as increased fibrinolysis. And the authors of this study concluded that the D-dimer and fibrin degradation product values may have had prognostic significance and also be important therapeutic targets. What happens with disseminated intravascular coagulation is that as a result of the virus, inflammation is created, sepsis occurs, and cytokine and tissue factor release also occurs. This results in increasing thrombin levels in the circulation, so the patient becomes hypercoagulable, more likely to clot. The body's response to that is to accelerate the fibrinolytic system. And then there's a fight between clotting and fibrinolysis. And sometimes those patients wind up being hypercoagulable, normal coagulable, or in the extreme setting, and very serious one, where they develop what we call a consumptive coagulopathy. And that is that the rate of destruction of these clotting products is so great that the prothrombin times and the partial thromboplastin times get very long, and the patient can bleed and actually bleed to death. At the same time, while there's a clotting process going on. Very complicated disease, very difficult, especially in the later stages, to really affect with treatment. In addition to that study, another study I have just seen was a meta-analysis that was a very well done piece about recommendations for prevention and treatment of venous thromboembolism associated with the coronavirus. These authors emphasize the importance of a complete risk factor assessment for patients who are at moderate or high risk using one of the available scores, such as the PADU or a Caprini Score. And of course, if they are moderate or high risk, they should have prophylaxis. Low molecular weight heparin was recommended for at least 7 to 10 days. As we know, that's the effective time required for efficacy for these drugs. But in addition to that, what's really more important is that the low molecular weight heparin should be continued until the risk factors are removed. In other words, treating the patient for the period of time that the patient's at risk. And this meant, in some cases, continuing prophylaxis following discharge, especially those with persistent risk factors, such as pneumonia, COPD, immobility, and the like. They also suggest that all severe coronavirus patients with pneumonia are at high risk and should receive anticoagulant prophylaxis unless there's a contraindication. Dehydration is another factor that was emphasized as a causative factor for developing venous thrombosis in these patients. Pregnant patients also need to be risk assessed, and prophylaxis recommended for those at risk during and following pregnancy, sometimes for 6 weeks or longer, postpartum, depending on the clinical situation. At all times, in all patients with this disease, a high degree of suspicion for venous thromboembolism should be done with screening at the drop of a hat for those that are suspected in any way of having a venous thrombosis, and certainly those that have abnormal clotting tests, particularly the D-dimer, which is a sensitive marker for thrombosis. Patients that develop DIC and consumptive coagulopathy, of course, require special treatment. Anticoagulation choices may have to be altered. It may have to be stopped. Antifibrinolytic drugs may need to be given. Mechanical methods are critical when these patients are in this stage of their disease. And the use of extracorporeal membrane oxygenation may be important in some cases. In conclusion of this study, the authors expressed that risk assessment and prevention of venous thromboembolism is particularly important in the overall comprehensive treatment of these patients with coronavirus. The condition of some patients is known to change rapidly, and the risk and outbreak of VTE during treatment is common, so that one has to be on top of these patients on a day-to-day and actually hour-to-hour period. There's a dynamic changes in blood risk, which should be dynamically assessed. For example, the D-dimer level goes up. You really should screen these patients for thrombosis, maybe adjust their anticoagulation, maybe increase it in some cases in order to reduce the incidence of VTE, which of course will factor into the eventual occurrence of fatalities. One of the best ways, in my opinion, to assess patients is with the Caprini Score, because it represents a thorough risk history and physical with 40 elements. And we know as the number of risk factors goes up, the incidence of VTE goes up, and also each risk factor has a power or tendency to develop thrombosis. And so by combining the relative powers of each of those risk factors and the number results in a score. And there is a nonlinear or linear, in the case of a particular population, increase in the score based on their chance of developing a venous thromboembolism. Here we see a nonlinear increase in general surgical patients. I'll show you later a more linear increase in patients in the ICU. Many risk forms can be used. Here is one common risk form that we use to evaluate these patients. I'd like to now discuss a very important paper that was published by Andrea Obi and her associates at the University of Michigan in 2015. This was a retrospective cohort study of 4,844 patients in the ICU over a 5-year period. The overall incidence of venous thromboembolism was 11.5%, and significantly higher in those with a score of over 8, where the incidence was 11.5%. And as the scores went down, the relative rate of thrombosis went down as well. The presence of pneumonia and central venous catheterizations increased the VTE risk. They had a very powerful determinant nature for VTE. And here's the linear increase. And as you can see, as the VTE rate does go up as the score goes up. So it's a very good correlation. So in conclusion, the presence of coronavirus creates significant problems regarding thrombosis, prophylaxis, and treatment. Traditional anticoagulants prevent venous thromboembolism, including fatal events. Most fatal events are prevented with an adequate course of heparin or low molecular weight heparin. Thrombosis prophylaxis is indicated for most patients. The presence of disseminated intravascular coagulation in the most serious cases may increase the risk of bleeding if a consumptive process exists. Standard coagulation tests can predict death from the coronavirus, and the Caprini scores can identify those who are high risk for thrombosis and death. So what is the value of combining these measurements? First of all, you improve the identification of overall patient risks. You have a patient with a high score and they also get a high D-dimer, that patient needs to be screened immediately to make sure they're not already don't have a clot. Then the anticoagulant prophylaxis has to be refined, and it depends on a variety of circumstances. Sometimes you'll have to increase the dose. Sometimes you'll have to decrease the dose depending on the chance of bleeding, presence of renal insufficiency, which can occur as a result of sepsis, and so forth. And the problems associated with DIC are many, and the anticoagulation may need to be adjusted, antifibrinolytics may be used, ECMO may be appropriate. There's a whole variety of circumstances that have to be carefully done according to the individual patient's characteristics. And finally, going forward, we need to explore the use of aspirin, factor XI inhibition, or E-selectin inhibition to provide appropriate thrombosis prophylaxis, since all of these methods have been shown to decrease bleeding rates compared to low molecular weight heparin. So I'd like to thank all of you for listening to this presentation and encouraging you all to visit my website for further information at venusdisease.com. And please, everybody, stay safe and have a great day. Thank you very much.